Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello and welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and today we are talking all about some of your top questions if you are trying to get pregnant or having infertility. Friends, I have to admit this is the end of an era. This is the last episode that has been recorded by me in my little room, edited by just me or trusty Kayla, who has edited this podcast now and been a part of my team for 5 years. We are so excited to be making the change and leveling up the podcast and finally bringing you in-person episodes recorded at a studio and some guests back to the show. So the new version of the As a Woman podcast is coming and I can't wait to share it with you. All right, before we dive into this episode talking about your top questions when it comes to trying to get pregnant and your cycle and infertility, I want you to make sure that you stay tuned to the newsletter to get all the latest updates. That is nataliecrawfordmd.com/newsletter. We also answer your questions on Monday over on Instagram at nataliecrawfordmd, and check out the YouTube channel. The YouTube channel is going to be hosting the new full-length podcast episodes. So go ahead and get over there and subscribe because I think it's going to be your new favorite way to watch the podcast or listen to it. But of course, we will also still stay in all your favorite podcast players, Spotify, Apple, whatever your heart desires, we're going to be right there. So thank you guys so much for all your love and support. I'm really excited that after this many years, we are changing the show up and doing things a little bit different. So let's jump in and talk about some of your top questions when it comes to trying to conceive.
Hi, Dr. Natalie. First of all, I just wanted to say thank you so much for making your content. I really appreciate it, and I know tons of other listeners do as well. My question is, I cannot for the life of me get a positive OPK test. I am 25 years old, trying to get pregnant. I was recently on the Mirena IUD for 5 years, and prior to that, I was on birth control pills for a year or two before that. I'm worried I might have endometriosis. I have had really painful periods, but birth control has helped with that a lot. I did have regular periods while using my Mirena IUD for the past 5 years. I would get cycles from 31 days to 40-ish days consistently throughout having the IUD in place, and I recently got the IUD taken out. I have been taking OPK tests every single day, and they're always negative. I take them between 10 and 11 o'clock every single day. I'm worried my urine might be too dilute or something, but any tips or concerns or any additional information you could provide to my situation would be greatly appreciated. I also have had a past history of an eating disorder that's kind of concerning me that I may or may not be ovulating, but I've never been without a period, whether on birth control or off of birth control, so I'm not quite sure how much of a concern this is. But yeah, any information you could provide would be amazing, and thank you so much for listening to this question. Bye.
All right, I know it can be really frustrating when you're trying to figure your body out and trying to track your cycle and nothing is making sense. If you're having regular periods or pretty regular periods and you're not on any contraception, you are almost certainly ovulating. Now, that doesn't mean it's normal or that there's not issues, and obviously not detecting it with OPK is a problem, but that should mean that you're ovulating. So let's just talk about OPKs and then a few ways that we might be able to improve the situation or also track. An ovulation predictor kit is a kit that you urinate on, and so it is an LH detection strip. It is looking for the LH surge. What happens is if we think about you have a group of eggs outside the vault. Remember, I like to imagine all your eggs are kept in a vault inside your ovary. So at the start of the month, you have a group of eggs that's all released from the vault. Each egg grows inside a follicle. Well, your brain is going to send out follicle stimulating hormone, or FSH, which is well named to get a follicle to grow. As that follicle grows, it makes estrogen, and that estrogen talks back to the brain to say an egg is growing. When the brain senses that high prolonged estrogen, it then is supposed to send out a surge of LH. And that surge of LH is the highest amount of LH you will have in a cycle. It will then allow the follicle to rupture, the egg to finalize maturity and be ovulated, and then the follicle will reform and become a corpus luteum. And that corpus luteum is going to make progesterone at pulses throughout the entire luteal phase, typically lasting for about 2 weeks until it is going to die. Progesterone will drop, and then you'll have a period, and the cycle will repeat itself. When you take an OPK, we're trying to detect the LH, which is a hormone released into your bloodstream, but we're trying to check it in your urine. So number one, we've got to give the hormone time to get into your urinary stream. Number two is that, yes, if your urine is too dilute, there may not be a high enough concentration to detect it. So different tips. One is, yes, I usually say the ideal time is between 10 a.m. to 2 p.m. If you're not getting positives, might check at the later end of that range or take a second OPK in the evening when you get home from work. Maybe for you, it's not quite in your urine at 10 to 11 a.m. and you're missing that window. So try a later time or even a secondary one in the afternoon. I also would say, let's try to do a little test for a cycle and restrict some of the fluid or not go to the bathroom for a while before using the OPK. So for 2 to 3 hours before you're going to, maybe don't drink as much. See if you can get a more concentrated sample of urine. I also would recommend seeing other related factors. So have you ever tried to check your cervical mucus? Because if your cervical mucus is making sense with your cycle, maybe we don't need ovulation predictor kits. Cervical mucus monitoring is a monitoring of the consistency of the cervical mucus. With this, your cervix is the entry point to your uterus, and sperm have to swim through the cervix to get into the uterine cavity. So if we think about the cervical mucus as something that it can provide a barrier or help with sperm entry, it changes in correspondence to estrogen and progesterone levels. So you will have no cervical mucus at the very beginning. It will then become a little bit creamier, and then you will get this sticky, stretchy egg white cervical mucus. And the way that you check cervical mucus is to go to the bathroom and wipe on the toilet paper immediately and see the secretions that are right there at the vulva. And then if you want to, you can pick them up and see if they stretch between your fingers. Literally should stretch like an egg white if it is type 4. That is strongly correlated, called type 4 cervical mucus, with ovulation. So we're looking for a positive OPK the day before or the day of that type 4 cervical mucus. And if you don't get positive OPK, but you have cervical mucus that is type 4, and then your period comes about 2 weeks after that if you're not pregnant, then that is a fertility awareness factor as well, and you don't need to mess with OPKs. So maybe they're just not the right test for you. Now, if our periods are irregular, we're really not being able to track anything, definitely recommend that you see a doctor so that you can have some blood work done to look for other causes which can interfere with ovulation and can interfere with the ability of your body to release FSH and LH. So ultimately, hoping you get to the bottom of the problem and wishing you lots of love on your TTC journey.
Hi, Dr. Crawford. I just wanted to say thank you so much. Your podcast has been so informative for me on my trying to conceive journey. I had a question about my cycle is very regular, like 28 to 29 days every single month. I have the same length of period, the same symptoms. It feels very regular, but I am ovulating on day 19 or 20 every time. So that means that my luteal phase is only 9 to 10 days at the most. And I've tried adding in various supplements, and I haven't done any hormonal treatments like progesterone, or Clomid, or letrozole, but I've done, like supplement therapy, and nothing seems to be helping. It's very consistently 19 and 20 days. Is it still possible to get pregnant with that? And, if not, what else can I do to help lengthen my luteal phase? And yeah, I just love any recommendations you have. Appreciate your help. Thanks. Bye.
Oh, I'm so sorry for the short luteal phase. I have been there before where I have been tracking my own cycles and had issues with my own luteal phase. So big hugs, because it often feels like nobody cares if you say your period is regular and then you try to go into specifics and you get really dismissed. So let's talk through a few different things. Number one, you can have some medical reasons why your luteal phase is short. So absolutely recommend that we get blood work testing, that you see a doctor. And if you're asking for testing, I would ask for a prolactin, a TSH, a thyroid test, and an AMH or a test of ovarian reserve. Want to make sure nothing is happening in those aspects because you might choose different treatment plans. Let's say everything there is normal. What we really want to see for a luteal phase is typically we want 14 would be the gold standard, 12 to 14 is pretty average, 11 is going to be right on that borderline, but less than 11 is definitely short. And so what can you do about that? Well, we definitely want to think about, is there anything in your world that's causing what I call hypothalamic dysfunction? Meaning you're not in full hypothalamic amenorrhea, the brain's not turned off, but is there something that's interfering with the brain's ability to sense the oncoming hormone signals or to send out enough signal to keep the LH being made for quite as long? So this might be things like, do you have a lot of stress? Are you not getting sleep? Do you have other medical problems? Do you have a lot of inflammation? Are you overweight? Are you not eating enough? Are you over exercising? Are you training for a marathon? A variety of things. That list was very large. Can interfere with the brain's ability to interpret what's happening in your body. And a lot of the connecting factor is often through inflammation. So is there anything that you can change or modify on that end that's going to set you up in a better position for success? A lot of times for women, it is not enough calories for your body size and over exercising. And I think we really have to switch gears if we're trying to get pregnant and look at food as nourishment, nutrients, fiber, and really try to fill up a diet with a lot of nutrient-dense foods. Outside of that, this is the first stage of ovulatory dysfunction, in my opinion. And so, yes, if you have high prolactin, we should be treating that with a dopamine agonist, so a medication to lower your prolactin. But if all the testing is coming back normal and maybe there's some vague lifestyle stuff you can do, my recommendation is not just progesterone at the end. So sometimes you see people who are given progesterone to take in the luteal phase, and that's not necessarily wrong, but it's a band-aid. It's not getting to the underlying dysfunction. Big asterisk, big red flag. Progesterone should not be taken every day of your cycle. I have seen so many patients who've had a low, quote unquote, low progesterone, and they are then given progesterone to regulate their cycle, but every single day. Taking progesterone every single day, even if it's at different doses, is by definition birth control. Remember that progesterone opens and closes the implantation window. So even if you're taking it in just the luteal phase, when you start it is really important in relation to when ovulation occurred. And if any question, you should start it later. I like to start it like 3 days after ovulation. So you know that that first progesterone start happened endogenously within your body and you're not interfering with that. My treatment of choice is ovulation induction medications after we've ruled out other things. And so these are medications like Clomid or Letrozole, depending on your clinical situation. Clomid is my favorite because it just binds right at the brain, allows the brain to send out a stronger signal of FSH. Letrozole requires the brain to interpret a lower estrogen signal because it decreases estrogen in the periphery. And I'm worried that the brain's already not interpreting great. So I just want to block that estrogen and have the brain go, oh my gosh, there's none. So that is why I prefer Clomid. But the idea here is that if I can get a better FSH signal, I can get a better follicle to grow. And then hopefully I'm in a better position to have a better corpus luteum and make more progesterone. And I often give progesterone in that context too, because I know when you ovulate, so I'm not worried about you starting it too early, and it's not going to hurt, especially because we know we're giving it at the right time of the cycle. So hopefully you can get to the bottom of the problem. From a supplement standpoint, my recommendations for a short luteal phase, of course, include a prenatal vitamin, but in addition to that would be CoQ10, vitamin E, vitamin C, and melatonin. So lots of your fruits, nuts have some of these really great nutrients in them.
Hi, Dr. Crawford. Thank you so much for your podcast, your transparency, your mission, your care of patients. First and foremost, from woman to woman, I just want to say you're a queen and a force of nature and you rock. Now for the question. So I'm about 3 months out from starting to try to conceive, and I wanted some specific clarification about folic acid and folate. I currently take a prenatal that has 1,000 micrograms of methylated folate, and the reason I chose this particular prenatal is because their ingredients are traceable and responsibly sourced, but also because I read that some women can't use synthetic folic acid, so it's safer to take it in the form that we get through our diet as folate. Then when I was reading your newsletter one day, you made the point that while folate is how we get this nutrient from our diet, all of the studies that have been done that show the protective factor against neural tube defects were all done with folic acid. So after reading that, I thought, well, I guess I'm just going to have to take both, because if I take just folate, then there actually aren't any studies telling me that's going to protect my kid from neural tube defects. And if I just take folic acid, there's no guarantee that I'll be able to use that synthetic form of that nutrient. But then I looked up, okay, so can you take too much folate/folic acid? And I found the answer is yes, you can take too much of it. And on top of that, I eat a primarily whole food plant-based diet, so I'm consuming a lot of folate-rich foods anyway on a daily basis. So I would love your advice. Should I stop taking the prenatal with the methylated folate and switch to synthetic folic acid? Should I alternate? Like one day take folate, the next day take folic acid? I'm not sure the best way to go about this. I just want to make absolutely sure that I have a rich supply of this very vital nutrient before I try to get pregnant. And also I would just love to hear your opinion on like a bullet point list of what should be in my prenatal, non-negotiables, the ingredient and the dose. Thank you so much.
Your question's so spot on. I'm just so thrilled to see it and to see that we're having these discussions in real time and really helping people. Is methylated folate okay? I mean, to be honest, it probably is, but probably is not good enough for me when it comes to my baby and the devastating consequence of a neural tube defect. A neural tube defect is where the spinal cord of the brain doesn't fully form, and these can be devastating outcomes. One of the things that has been shown to prevent neural tube defects is folic acid supplementation. And this is specifically synthetic folic acid, like we talked about, not the methylated version of folate. Now, we also have food that can be fortified with synthetic folic acid, things like breakfast cereals or breads and pastas. And that was done to try to help prevent this deficiency in vitamin B9 or in folic acid. So if you have a high plant-based diet, you are probably taking in lots of natural folate. So things like dark leafy green vegetables, nuts, legumes, fruits, those are very high in natural folate. Some people don't have access to those foods, or those foods can be expensive, and a prenatal vitamin can be a lot easier way. As far as methylated folate, you're already getting an active form of folate in all of those dark leafy greens that you are consuming. So I would recommend taking an additional 400 micrograms mcgs of folic acid in folic acid form, since that's the only thing that's been studied to prevent a neural tube defect. Methylated folate is a downstream metabolite, and even though it makes sense that it should do the job, it is not proven to do so in studies in pregnancy, nor will that study ever likely exist, because we could not risk ethically subjecting a group to less than standard of care treatment for something as severe as a birth defect. That being said, if you like your prenatal, I'm not worried about one additional 400 micrograms of folic acid added to your regimen. In fact, folic acid is vitamin B9, and that's a water-soluble vitamin, so any excess that you're going to have, you're just going to pee out. So if you were only going to take one pill, I would have you take a folic acid, synthetic folic acid version, especially with your diet, where I'm sure you're getting tons of folate-rich foods in your diet. However, if you like your prenatal, I'm not opposed to you taking just an additional folic acid supplementation and keeping on your prenatal as is. That's not going to be detrimental. I'm not worried about harm. As far as some women using one form better than the other, that's probably overdrawn, especially when it comes to pregnancy, because a baby takes what it needs. And what I always say to my patients is what you may need when you're not pregnant, what may be best for you, and what you may need right now when you're pregnant are going to be different things. So if you, non-pregnant, not trying to get pregnant, maybe you do process methylated folate easier and that helps you feel better. But when it comes to a pregnancy, what you need in this time is the folic acid that's proven to prevent a neural tube defect. So hopefully that helps it make sense between the difference of it. And if I were you, I would literally just go buy a 400 microgram folic acid standalone nutrient pill, and I would just take that in addition to my prenatal. What do I love in my prenatal vitamin? Okay, here is my favorite list if I was going to make a prenatal. 400 mcgs of folic acid, at least 600 IUs of vitamin D3, 1,000 milligrams of calcium, 300 milligrams of omega-3 fatty acids, 450 milligrams of choline, 770 micrograms of vitamin A, 1.9 milligrams of vitamin B6, 2.6 micrograms of vitamin B12, 220 micrograms of iodine, 27 milligrams of iron, and 85 milligrams of vitamin C. That is based on what has been shown to be the healthiest things that you need for your baby's development. A lot of these nutrients can come from food, and of course, in the perfect world, it would all come from your diet. But the reality is, we don't always eat a perfect diet every single day, and growing a human takes a lot of nutrients, and I want you to have everything you need to grow a healthy baby.
Hi, thank you for taking the time to answer questions and all of the information that you give us. I had a question regarding PCOS and trying to conceive a second child. I'm 31 and have a 2-year-old, and I was initially given metformin for irregular periods, and we actually got pregnant within 3 cycles of starting the metformin, which was great, had a healthy baby and a good pregnancy. And then we started trying for a second child about a year postpartum. We were going on 13 months now of trying with no success, and I was just recently referred to a fertility clinic. My cycles now are what I would say regularly abnormal, where it appears that I ovulate between days 21 and 24, and then have about 8 days before I start my period. So an extremely short luteal phase, and it appears to be a delayed ovulation. I get positive LH tests, cervical mucus, a little bit of cramping, and my temperatures do rise, but it appears they don't rise as significantly as I would expect with like a healthy ovulation. And then that period comes like 8 days later. I went to my first appointment the other day and they did blood work, but I haven't gotten the results back from that yet. The last time I had my thyroid checked, my levels were good. I do take medicine for that as well. And we are going to do a semen analysis and see where that's at. But they suggested going ahead to starting letrozole and then doing a trigger shot as I just started a cycle. So the plan is letrozole, a trigger shot, and then timed intercourse unless something comes back from the semen analysis where we would do an IUI. And I know you had mentioned before that if you regularly ovulate, then letrozole and timed intercourse, statistically probably isn't going to do anything. I was wondering if that's the same case for like abnormal ovulation, where perhaps like the quality of ovulation isn't where it should be, like my situation. They also suggested maybe I'm not ovulating as regularly as I think I am, even though all the signs are there. And so I was just wondering if, based on what you said before, if this seems like a course of action that makes sense, or if you would do something different, or some questions I should ask. I'm pretty new to the infertility clinic and these things, so trying to make sure that I ask the right questions and don't waste money or time. So any insight you have into it would be helpful. They didn't say anything about progesterone either, but I was wondering if that's something that should be given on the other end as well. So thank you so much for taking the time. Bye.
Okay, great question. And you answered it yourself along the way. So I love that. Yes, doing ovulation induction like letrozole with timed intercourse does not add anything to the picture if you have unexplained infertility and perfectly regular cycles. However, it sounds like that's not your case because your cycles do not sound perfectly regular. Notably, this is a very short luteal phase. So the reason to do the ovulation induction, the letrozole, is like what I said before with the short luteal phase, is that we're trying to normalize your cycle. And if we can get a better egg to grow, maybe we can have a better, stronger corpus luteum to make more progesterone. So I actually agree with the treatment strategy. I usually prefer Clomid. Letrozole's not wrong. If you respond to it, great. As far as what happens with the cycle, I think it's important to know, are they going to be monitoring with ultrasound? I presume yes, and that's how they'll determine when you use the trigger shot. I like the flexibility with the plan based on the semen analysis, should you do timed intercourse or an IUI. And progesterone, when I trained in fellowship, we didn't do progesterone for this because I can fix your corpus luteum because it's not ovulating well. I'm fixing the problem. And I saw great results. I give progesterone now mostly because peace of mind. It's likely not doing much more that the ovulation induction is not doing. So your treatment team is not wrong. That being said, if it will give you peace of mind, you also could ask your care team if you could supplement with progesterone in the luteal fees to see if that would make a difference and would help things out. But I think this is a perfectly appropriate treatment plan. I like that the blood work is checked first to make sure there's no new thyroid or prolactin abnormality, and ovulation induction would be my recommendation as well. So sending you lots of good vibes and hoping you get pregnant. All right, friends. Well, this is going to be the last question we have on this iteration of the podcast. Don't forget, the podcast is staying. It's just changing. It's going to be even better. And you want to be signed up for that newsletter at nataliecrawfordmd.com/newsletter so you can still get your questions answered. We will be collecting questions from there to be included in the new season of the podcast coming soon.
Hello. Thank you so much for listening to this message. And my message is regarding what to do next to best improve my chances of getting pregnant with endometriosis. So I've listened to your previous podcast before about endometriosis and the cases of those that suspect it in terms of fertility. However, I was recently diagnosed with it. I just had a laparoscopy at the end of January. And I was diagnosed with stage 2. So it was widespread, but it did not create any adhesions or scarring. They also did the dye test in my fallopian tubes and found that everything was clear and open. I've been to a fertility specialist and gotten all my testing done, and everything has been within normal range except for my vitamin D, which I've been taking vitamin D supplements for over 6 months now. So my question is where do I go from here in terms of creating the best chances of becoming pregnant? I am 25. I have a little bit of a lower AMH. I have an AMH of 2. So not like ideal, but also not the worst. But with endometriosis, it's really tricky because I'm fighting time as well, time with my biological age and my quality, but as well as the endometriosis building back up. My doctor told me that I could either go back on birth control and let my pelvis continue to heal from the surgery, or now that everything's all flushed out and open, just start trying for about 6 months until I probably need to go on birth control again. So I guess my question is, what's the balancing act between letting my body heal from endometriosis and then also trying to conceive, and what will best promote my chances of getting pregnant? And how often do I need to oscillate between trying and then trying for a baby and then also preventing my endometriosis and going on birth control? Thank you so much. Bye.
Well, endometriosis is something that I purely despise. I just hate what it does to the body, and I hate how hard it is to get anything taken seriously if you do have endo. So I'm sending you a big hug because I know that there's so much that goes into it, and I just want you to know that I'm here for you. A couple things that I think are really important to think about when it comes to what your next steps are. So birth control pills do not regress endometriosis. They're not a treatment for it. However, ovulating makes endometriosis worse. And that is because with each ovulation and each stimulation with estrogen of those endometriosis lesions, the disease progresses and gets worse. So by preventing ovulation, we are slowing down the progression of the disease. So where I view your treatment options as if you are not ready to get pregnant, I would say start birth control and try to put a little bit of a pause or a slowdown on what we know is the inevitable. You had endo, they took it out, it'll most likely come back. So can we slow down that so that you're not dealing with this when you're ready to get pregnant? On the other hand, if you have surgery and you have known stage 3 or 4 disease, it is going to be very hard, not impossible, to conceive naturally. Many women with high stage disease have to go on to IVF. Women with lower stage disease, so 1 or 2, do have improved pregnancy rates pretty significantly after surgery. So those first 6 months after surgery, you have your highest pregnancy rates. And so to me, you're in that perfect golden zone. We just decreased some of the burden of the disease. Hopefully inflammation is down, and this would be the time to get pregnant. So my thoughts are complete the fertility evaluation. If you haven't, hopefully that was already done. Make sure your cycles are regular. If they are not, start on ovulation induction medication right away. If everything is normal and you just want to try to get pregnant naturally, I would absolutely track my cycles, time intercourse, and give it the best go. If you're not pregnant after 6 months, though, going back and doing birth control is not changing what's happening. Meaning at that point, you're likely going to start to have endometriosis coming back, and you might just need more aggressive fertility treatments to get pregnant. So there's no one size fits all. Not every endo is the same. I have patients with stage 1 disease who need IVF and some with stage 4 who do get pregnant naturally. So everybody's not equal or the same. But in your situation, if it were me and I just had surgery and I had stage 2 disease and it was taken out and my tubes were open, I'd make sure I had the rest of my fertility testing, ovarian reserve, hormones, semen analysis, and then I would start trying right away with the goal to hopefully get pregnant in the next 6 months. And if I wasn't pregnant after that, would want to schedule an appointment with a fertility doctor and talk through what the best steps were. Similarly, if your egg count's low or the semen analysis is abnormal or your periods are not regular, see a fertility doctor right away. Okay, friends, well, that is a wrap. And this show started January of 2019. It is May of 2025. The show is continuing, but it's time for the next version. So we'll be progressing on to season 3, which will be taking the show to an even better place with more in-depth conversations. And I just think you're going to be so excited about it. We've been working on this for a long time, and I can't wait to bring you along on the ride. Every single sweet word and comment you say at the beginning of these episodes, that means so much to me. Every question you leave and you say how the show has helped you, that's why the show exists. So thank you so much for all those kind words. Would love it if you want to go review the show. That always helps. People do look at those Apple reviews, you know. And then also if you want to share it and show more people about the show so that as it's changing into its new format, we can get more eyes on it. That would mean so much to me. As always, you can follow along on Instagram at nataliecrawfordmd, sign up for the newsletter at nataliecrawfordmd.com/newsletter, and go subscribe to the YouTube channel because more exciting things are going to be happening over there. Until next time, thanks, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.